Hello everyone and welcome to our Difficult to Diagnose Cancers Primary Care Cancer webinar. I'm Zara Gross and I'm the Early Diagnosis Cancer Lead for South East London Cancer Alliance. I'm going to quickly go through some housekeeping information and then introduce our panel of speakers. So just a couple of points around housekeeping. Everyone will be muted and your cameras will be off by default. If you have any questions during the presentations, then you will have a Q&A box at the bottom of your screen, and please type in any of your questions that you'd like to have answered by our panelists. If you'd also like any of the video or audio to be switched on, please also add that into the Q&A box when you're answering your question. If you have any technical issues, then please let us know. We have Bav from Guy's Cancer Academy on hand to sort any technical issues out, hopefully. And finally, you'll receive a certificate of attendance for today's webinar. You'll receive that on completion of your evaluation form. A link to the evaluation form will be sent directly after this webinar. We just ask you to complete that. We've got a series of webinars taking place, and we obviously want to improve them on every webinar that takes place. So I'm going to quickly introduce our panel of speakers. So for myeloma, which is starting first, we've got Dr. Winnie Kwan and Dr. Carmel Rice. Winnie is our GP cancer lead in Bexley, and she's also our GP education lead for South East London Cancer Alliance. And Dr. Carmel Rice is Locum consultant haematologist at King's College Hospital. We've then got ovarian cancer, so we'll be looking at ovarian cancer with Dr. Esther Appleby. So she's our GP cancer lead in Lewisham, and she's also the GP lead for personalised care in South East London Cancer Alliance. And Mr. Rahul Nath, who is consultant gynaecological oncologist at Guy's and St Thomas's Hospital, and he's also the chair of the South East London Gynaecology Tumour Board. And then finally, we've got Pancreatic, and we'll be joined by Dewar, who's a gastroenterology consultant at Lewisham and Greenwich Hospital. So Winnie, over to you.
Thank you, Zara. Hello, everyone. We aim to help you to feel more informed, equipped, and empowered to make the necessary two-way referrals for some of these difficult to diagnose cancers. So, why are certain cancers difficult to diagnose? Next, Zara, please. Mm-hmm. Because they're rare, because sometimes they present with vague, non-specific symptoms, and sometimes they require a stepwise investigative approach such that it results in multiple primary care consultations prior to the referral. Next, please. So how can we improve the diagnostic process to make it easier for us? So here are some suggestions. Obviously, improving our cancer knowledge base. We know that the NG12 guidance has got a shelf life in our brains, and maybe we want to learn in other ways, such as webinar like this. And by the way, we are planning on doing another one in the future on sarcoma and pediatric cancers. I would recommend also Gateway C, which is a great education resource for primary care, because it has got modules on difficult to diagnose cancers in the primary care setting. Obviously, CRU UK Macmillan has got lots and lots of education resource. I won't go through the whole list. Now, so at the clinical level, first of all, maybe we should build into our consciousness some alerts for some symptom characteristics, like the persistent fatigue, the unintentional weight loss, the persistent pain, the vague abdominal symptoms, complicated by perhaps comorbidities as well. And we should maybe also put in an alert for the rare attenders, the people who never used to come and suddenly turn up, or the people who come several times for the same unresolved symptoms. And obviously not forgetting that young people can get cancers too. So at a more granular level, we might want to look at our communicative process. Are we actively listening to the patients, picking out the signals of the worrying symptoms, and asking for the red flags if none of it is forthcoming? And at the end of the day, it's our thinking process. I think we have to make sure that neither the patient and we normalizing the symptoms, because we can again go down the wrong route, and whether there are any suppositions, and are we keeping an open mind about the whole situation. Next, please. So that's the question. Could this be cancer? So what can help us? The clinical decision support tools. Macmillan has combined the cancer risk assessment tool with Q-Cancer and set a positive predictive value at 2% to pick up early cancer symptoms. So NG12 guidance has set the PPV at 3% for referral. Now, Cedars-Sinai is another system. It risk assesses against NG12 guidance and recommend course of action. It's got other functionalities. And in Southeast London, the Cancer Alliance is actually supporting pilots on both CDS tools. If anybody's interested, there is a link to a Macmillan report with more details on the clinical decision support tools. Gut feeling. Now, gut feeling is very important, is relevant, and it's got positive predictive value. If anybody wants to understand more about gut feelings and the cancer diagnostic process, there is a link here to a meta-analysis and systematic review at the British Journal of General Practice, just hot off the press in August. So have a read. It's really interesting. I mean, sorry, just going back. Yeah, obviously not forgetting physical examinations, very important, and we can get prompt diagnostics like blood tests. So with all that information, we should be able to make the necessary 2-week wait either tumor specific or use the RDC, the Rapid Diagnostic Clinic. Now, safety netting and learning events analysis, we'll leave it till the later on in our webinar series. Next. So the RDC at GST has shared with us certain statistics. Since 2018, they have picked up 8 myeloma diagnoses, and the average diagnostic to referral to diagnostic interval is 48 days for myeloma. So hence this webinar. Most common reasons for referral to the RDC was anemia, weight loss, and worsening lethargy. So next, please. In this webinar, we've enclosed some information on the RDC, as well as, next one please, as well as Myeloma UK, which has got the latest myeloma diagnosis pathways and the diagnostics tool for GPs. So at this point, I will then hand over to Dr. Carmel Rice for her to talk to us about myeloma. Thank you.
Thanks very much, Winnie. I hope you can all hear me. Thank you for that lovely introduction. And I think that leads really nicely into myeloma and what we're going to discuss. So what is myeloma? Here's just a brief kind of overview. I've tried to increase my volume myself because I think I'm a little bit hard to hear, so apologies for that. It's a cancer of plasma cells, those mature cells which make serum immunoglobulins. So patients often present with recurrent infections. They can get bone infiltration from increased plasma cell numbers within the bone marrow. It increases osteoclast activation, so it leads to fractures, particularly vertebral wedge fractures, and that can obviously lead to difficulty in diagnosing if you've maybe got an older patient who's also got risk factors for osteoporosis. That can lead to hypercalcemia, but that's often quite a late sign. Persistent pain, that's something we'll come back to, and I think that was something that Winnie highlighted as well in her talk. Somebody who keeps coming back with pain is something to really, dig a little deeper and look into that. And again, particularly in the younger patients. I think renal dysfunction we'd all recognise is a very common presentation due to direct damage either from the light chains or the paraprotein itself. Anemia, again, which can be multifactorial, and there can be lots of other causes for that. And we've talked about the fact that they get infections. And I guess the real reason that I think it's really important nowadays for us to try and diagnose myeloma earlier is for 2 reasons. It's an incurable cancer, but actually the treatments have improved greatly way since I was in medical school and even since I started in haematology practice. And so patients with lower risk cytogenetics may live up to 8 or 10 years with their myeloma with multiple therapies, and also, obviously autologous stem cell transplants. And there's so if they're diagnosed earlier, obviously they will do better, but there's the great capacity for preventing morbidity, particularly from skeletal related events, preventing people getting those fractures, which cause them a lot of problems and pain as they're living with their myeloma. yeah, so the survival, in low risk genetics has improved, and even patients with higher risk genetics, between sort of 2 and 5 years. Next slide, please. So how does it present? Well, in a myriad of ways. It could be that non-specific anemia that you're investigating. It could just be some recurrent back or bony pain. Patients may just feel a little bit more tired. They're getting a few more infections than normal. And when you're, seeing a big list of patients every day who've got lots of different symptoms, it's very hard to, I appreciate, weed out those patients who then turn out to have myeloma when it's such a rare presentation, and there are so many other reasons that could be causing that. But I guess there's a few simple tests that we could do that might maybe highlight who should be referred, or at least discussed maybe via advice and guidance for that. We've talked about why it matters in terms of preventing comorbidities and the pain related to skeletal events, but obviously patients can also get end organ damage. And for those patients who develop irreversible renal failure, actually the fact that they might need to go on dialysis increases their risk of death much more greatly than their myeloma does. So that's obviously a significant thing to wish to improve. The patients who present via emergency care, we said it was, over a third of patients, obviously they're coming in often in extremis. So those patients have a reduced survival because they've often presented with complications. And one of the things we also see then, and sometimes it can make it quite difficult, particularly in specific populations, that the patients have recurrently presented with symptoms and felt that they weren't sort of listened to, or it took a long time to get there. And then when they eventually get diagnosed, we have to do a lot of work to kind of get them maybe to re-engage with healthcare and to trust us, I guess, in delivering their treatment. Next slide, please. So we said the symptoms can be vague. Back pain, I'm sure you see, tons of that. But I guess for the people I see sometimes, I can think of a lady I've seen recently, a very young lady, otherwise very well, running, doing other things, looking really very fit, but this persistent, significant pain, the kind of pain she was needing non-steroidals for paracetamol, and then actually opioids, seeing a physio, not getting better, and eventually she had to organise her own private MRI, and that showed that an uptake in her marrow, and then she was referred on to us. So maybe in that situation, if she'd had some simple blood tests earlier on that may have shown some features, that may have led to an early diagnosis, because she was actually anemic when she presented to us and had a raised globulin level. Back pain, we get taught in medical school is a very common symptom, but actually a lot of patients present with other bony pains. And again, it's the persistent nature of those pains which is really important to pick up. And I've had some patients where it's muscle pains. And again, if you're not entirely sure in that context, doing some blood tests like a basic renal profile and liver function tests and the full blood count can be really helpful. And also just being alert to those people who are getting recurrent infections. And then doing the blood test. So yeah, I think one of my key takeaway messages would be anybody with persistent unexplained pain or just generally unwell or some anemia of unexplained cause, to do that myeloma screen, check their serum protein electrophoresis, and if you're able to, serum free light chains to go with that as well. Next slide, please. There's a lot of MGUS, so you'll often pick up paraproteins doing this that may not be related to their symptoms, but then again, they can be referred to us and then we can decide whether they need to do a bone marrow to sort of tease that out. Myeloma is always preceded by MGUS, and MGUS is really common, so probably if you start doing these screens, you'll pick up a lot more MGUS than you will myeloma, but that's okay because we can arrange to monitor those patients because a proportion of those will transform and then they'll sort of be in their system having regular monitoring, and that might also be another way down the line that means that we pick up myeloma earlier is because we're monitoring those MGUS patients. The patients who are at higher risk from MGUS of transforming are anybody with a paraprotein of 15. So anybody who's got a paraprotein of 2 or 3 that's been picked up, we probably just see them routinely in the clinic. But somebody who's got a higher paraprotein of 15, we'd see a bit sooner, and that's probably somebody I'll do a bone marrow on just to check that it wasn't smoldering myeloma, even if the rest of their parameters were normal, just to give you a bit of a gauge. Patients who've got an IgG myeloma are less likely to transform, and patients who've got an abnormal free light chain ratio are more likely to transform as well. Next slide, please. So these are the screening tests, very well, the full blood count, the ESR. People often refer patients a lot being very worried about raised ESRs, but obviously there can be a myriad of reasons for that, other inflammatory conditions, post-infective. So it's about looking at the pattern, serum creatinine and the calcium, the immunoglobulins and the serum protein electrophoresis. Again, we often get people are referred to us with a raised total IgG, but if somebody's just had an an infection, that could be a polyclonal, a normal response. And again, your ESR might be up with that as well. So having the serum protein electrophoresis to see if there's actually a clonal paraprotein there, that's what we're sort of looking for. Urine Bence-Jones protein, we don't do so much of that because the serum free light chains essentially have replaced that. So that can be a helpful thing to do. And just for your sort of information, imaging wise, we no longer do the whole body skeletal surveys because it's not actually that very sensitive. So anybody we've got high suspicion of, we're actually doing PET CT or whole body MRI on to pick up those early skeletal lesions. Just a word on serum free light chains. So again, that's another reason why people are commonly referred to our clinics. And I think it's sometimes quite hard to interpret these, but so I've just sort of given you some, I suppose, numbers at the bottom to give you a bit of kind of reference range. So what we're looking for here with myeloma is a clonal problem. So if you've got a kappa or a lambda which is increased out of proportion to the other one, so the kappa is really high but the lambda is normal, and then the ratio is abnormal, that could be a clonal disorder. If they're both raised and also the ratio is up, then that's more like a polyclonal response, or maybe something that you see in renal failure. And it's important to know as well that people who get these polyclonal rises may also have an underlying viral problem. So we've often picked up people who've been referred to our clinic who actually have undiagnosed HIV because it's causing the rise in the light chains. So just some figures, kappa lambda ratio, when you get those numbers back from the lab, if it's above 7, that's probably a good thing to be sort of referring to us, or less than 0.8. Paraproteins above 10. There'll be a few people who fall outside these parameters. So obviously your clinical suspicion, if they've got other symptoms, that would be a good reason to sort of refer. Because there are rare cases of non-secretory myeloma where you don't actually see any blood changes. So obviously, you know, using that gut feeling, and I'm glad to hear that there's evidence base behind that feeling. So something's not quite right, and the patient needs to be seen. Next slide, please. So yeah, so basically, when should you think, could this be myeloma? Anemia and persistent back pain, those patients with recurrent infections, hypercalcemia, again, that's advanced, renal failure, and then raised globulins. So I appreciate that not all labs release this, but in the King's lab they do, and the couple of patients that we looked at for a presentation at our grand rounds, again, looking at this area of late presentations, and I'll highlight this in one of the cases that we're about to talk in where somebody had raised globulins. So basically that means their total protein was high, but the albumin was low, telling you that there's something else there making up the globulin fraction, and that's the abnormal gamma globulins, the paraproteins. So that should be sort of a prompt to check those. Next slide, please. Okay, so these are just 2 very quick cases just to highlight some things. So this is a lady who actually presented through the hospital, and she'd come in for an appendicectomy. She'd had some blood counts, just routine screening with her GP historically that we got that were all perfectly normal, and they're on the left-hand side of the screen. And on the right-hand side was when she came in for her not elective procedure, sorry. She'd been in, I think, for a gallbladder procedure prior to the appendicectomy, and she actually was quite anemic, had some renal impairment, and had this very raised total protein of 115 that nobody seemed to take any notice of, even though she was very anemic with that albumin. So you can see there's the gap. If they checked her globulins or done myeloma screen at that point doing her electrophoresis, they would have seen that she had a paraprotein. Her calcium was normal, interestingly, and her CRP was a little bit up. So that's sort of a pattern of something I would look at and be very worried about. Next slide, please. So there's always a cause for anemia. This was obviously to look for that. And the myeloma screen, as well as doing iron studies and hematinics, B12 folate should be part of that. It's quite an easy test to order. Just check the immunoglobulins. And then anemia plus renal failure, or anemia plus back pain, is, I guess, a kind of little clinical vignette. So I'm always thinking myeloma. I'm probably always thinking myeloma because I'm a myeloma doctor. I'm probably thinking lots of other things. But yeah, that's just one of the things on the list to tick off. This lady, unfortunately, then needed dialysis, and eventually, when she had some treatment, actually, she was able to be weaned off it later down the track. Next slide, please. And I'm just aware of the time, so I'm going to quickly go through this case. So this was a younger lady of 41, Afro-Caribbean background, in which myeloma is said to, it is more common, and often we see younger patients, unfortunately, also presenting with a more aggressive phenotype of myeloma as well. And she developed really severe back pain, and it was sort of out of context with her history. I think she just kicked a step and then just got a sudden terrible pain in her back, and she went through that cycle of what I said, lots of analgesia, seeing physio, and this wasn't the lady who ordered her own MRI, but she eventually sort of came into us, and her blood, she was very immobile. She went from being a very fit lady in her 40s to walking with a stick, so it was clear that something was going on, but she'd had multiple presentations to a number of healthcare providers before before coming to us. And when she came to us, she had raised ESR. Again, you can see that raised total protein with the albumin gap. Her globulin was up, and she had a normal serum calcium, and she was anemic. So you can really see, I think, the things that are coming out of this are the anemia, the raised total proteins, back pain, and then often things like the renal impairment and the raised calcium come a little bit later. Next slide. I think that might be my last slide. So apologies, I've run a little bit over, but I'd be very happy to take any quick questions if there are any of those.
We've got one question that is around what is your myeloma screen. I'm just very aware of the time. So I would recommend, can we answer that via the text box? And then what we'll do for all attendees, we'll share that with everyone following the webinar. So everyone will have the Q&As, and so you'll be able to access those.
Yes.
Great. Thank you both very, very much. Now on to the next one. So Esther and Rahul.
As Zara just mentioned, I'm going to talk about ovarian cancer, and I'm going to give a bit of background to the tumour types and the sort of primary care end before, in the case of ovarian tumours, Mr. Rahul Nath is then going to present more from a secondary care point of view. And Rahul's very kindly going to interject during my presentation if there are particular points that he wants to make. Okay, so next, Sarah. Okay, so these statistics are very much based on the Cancer Research UK statistics. So ovarian cancer is the 6th most common in females, and it tends to increase with increasing age. So the incidence does vary with age, and it's highest in females between 75 and 95, 75 and 79. 6 in 10 are actually diagnosed at quite a late stage, and it's more common in Caucasian women. As you can see, the survival rates are fairly poor, particularly the 5-year survival at 40%. It tends to be that younger women tend to have a better survival rate as well. Thank you, Zara. These are rather concerning statistics, as you can see. About 1/3 of patients are diagnosed by the 2-week wait, which is pretty low. 27% diagnosed by the emergency route, and 1/4 by routine or non-2-week wait urgent referrals. So that just highlights the fact that it's clearly not something that we pick up on very easily in primary care.
So just to add to the points that Esther made, I think most people, certainly when I speak to GPs, but also members of the public, think that ovarian cancer is the most common gynecological malignancy. And certainly it was until about 5 years ago. The commonest gynecological malignancy now, however, is endometrial cancer. And that's predominantly driven by the fact that there is an increased prevalence of obesity, and that's driving estrogen to rise and an increased incidence of endometrial cancer. The other point I wanted to raise was around stage migration. So we know that patients who present with more advanced stage disease, stage 3 and stage 4 disease, will have a poor survival. And that applies pretty much to any tumour type. So if you can identify a patient with an early stage of tumour just because they've got symptoms, then it's much more likely that you will impact on survival. So what's interesting, I guess, comparing endometrial cancer and ovarian cancer is endometrial cancer tends to present with symptoms of postmenopausal bleeding at an early stage, and as a result, patients tend to be diagnosed when they have a stage 1 tumour, and as a result, their survival is very much higher at perhaps 80 to 85%. In ovarian cancer, if we catch patients with symptoms at an early stage and we catch them with a stage 1 tumour, then they're more likely to have a better 1 and 5 year survival. So what's interesting to us in the centre when we analyse our data is that, interestingly, in South London, compared to other parts of England and Wales, we have one of the highest percentages or proportions of patients presenting with stage 1 disease. Now, why is that the case? Well, we're not entirely sure. However, what we do know is we have a slightly higher proportion of women presenting premenopausally, in other words, while they're still menstruating, and often menstrual disturbance will alert our colleagues in primary care to organise an ultrasound, and that may then pick up an ovarian cyst. And that obviously, whether we do the CA-125 first or the ultrasound first, may identify patients who have what looks like a complex ovarian cyst, and then they feed through into secondary care. So I think that's quite interesting and local to Southeast London. So Esther, over to you.
This slide about the risk factors is actually a little bit different to some of the risk factors from the case control studies. So this is what actually appears in the sort of more public domain, as it were, increasing age, increasing BMI, and the use of HRT, and the obviously genetic risk factors. But I think Mr. Nath is going to come on to how this is reflected in the case control studies, because there's quite a bit of difference. So I'm not going to dwell on this slide very much. Zara, could we go on to the next one, please? This was actually in the SIGN publication guidelines, and I thought this was quite interesting because we typically imagine ovarian cancer to be a silent cancer, and this slide actually can suggest that that's not the case. A number of case control studies investigating symptoms in women with ovarian cancer and comparing them to symptoms in women without ovarian cancer demonstrate that patients with ovarian cancer are symptomatic for a variable period before diagnosis, and challenge the perception of cancer as ovarian cancer as a silent killer. So I think the patients I've seen in primary care have all had symptoms, and they've often had quite difficult symptoms that maybe cross several different symptom systems before they've been diagnosed. So just as Winnie mentioned us having a sort of mental trigger for particular symptoms, I think someone presenting with diffuse or lower abdominal pain, urinary symptoms and bowel symptoms, possibly crossing over between several, and that they go on over periods of time, I think that's very important to remember. Next slide, please, Zara. So presenting symptoms, symptoms present frequently or more than 12 times per month are particularly indicative of ovarian cancer, and they can be quite vague. So abdominal distension, bloating, early satiety and loss of appetite, pelvic or abdominal pain, increased urgency or frequency of micturition, and postmenopausal bleeding or intermenstrual bleeding. Changes in weight and changes in bowel habit. Next slide, please, Sarah.
Can I just interject
now the
there,
NG12 and the Pan-London guidance do differ slightly. NG12 advocates a CA-125 and then a transvaginal scan if the CA-125 is raised. When the Pan-London steering group were actually looking at the NG12 and working out what the Pan-London guidance was going to be, it was felt that it was far more appropriate to do both those investigations simultaneously in London. The reason for that is that CA-125 can miss up to 20% of ovarian cancer, and so for that reason, it's recommended within London to actually do a CA-125 and request a transvaginal ultrasound scan simultaneously. Right, next slide, please. Okay, so at this point, I'm going to hand over to Rahul just to continue the presentation from the secondary care point of view, and possibly comment on the risk factors that have been proved to be a little bit controversial. So thank you very much.
Thank you. Do you mind? I'm going to use Esther's slides just as a template for the talk. If we can just come back onto risk factors. So I think it comes back to what I was saying a little bit earlier around perhaps a comparison between endometrial and ovarian cancer and risk factors. The risk factors for ovarian cancer, I guess, relate to the patients presenting. So we heard right on the very first slide that patients tend to be older. The greatest prevalence is in women ages 75 to 79. But I think we mustn't forget that we still see ovarian cancer in younger women who are premenopausal. We also see ovarian cancer in women increasing from the age of 50 onwards. And so anyone presenting with symptoms of persistent abdominal bloating or distension, heartburn or indigestion, any change in the way that they're passing urine, so pressure symptoms with increased urinary frequency or a change in bowel habit, is, in my mind, a patient who potentially may have ovarian cancer when they're postmenopausal. And so certainly NICE guidance changed that we need to think as all of those as red flag symptoms and consider a CA125 with an ultrasound. The point that was raised by Esther, that the CA125 is normal in 20% of ovarian cancers, is very relevant, because what we know is of women with stage 1 ovarian cancer, half of them will have a normal CA125. And so if patients have a normal CA125, it is important to still do an ultrasound, particularly if on pelvic exam you feel that there is a mass. And in terms of the features on ultrasound, the things that would trigger alarm bells are not a simple unilocular cyst with a normal CA125, but it's more around the complex nature of the cyst. And so on ultrasound, what we're worried about in secondary care is if there is a comment that there are solid components, the cysts are bilateral. There's a comment around fluid in the abdomen, so they comment on ascites. A radiographer should be able to pick up metastatic deposits on imaging. So if there is a comment of peritoneal solid components separate to the ovary, then that is the type of thing that would ring alarm bells. So even though one may have a normal CA125, if any of those other features are seen on ultrasound, that would also be important to trigger a 2-week wait referral to secondary care. Coming back to these risk factors, in premenopausal women, women may present with a change in bleeding pattern, so a story of intermenstrual bleeding, a story of postcoital bleeding, a story of discomfort during intercourse or increasing pain during periods is relevant. That may then trigger the patient to have an ultrasound, and that would then be the factor that would pick up that the patient may well have an ovarian cancer. As I said, most patients with ovarian cancer who are younger and are still having periods will very often be picked up with earlier stage disease. Now, is it that their natural history of ovarian cancer is different? I think the answer is no, but I think they're probably more attuned to the fact that their menstrual patterns change, and that then triggers a visit to the GP, who may well then organise an ultrasound at an earlier stage. So that may be the reason why we pick them up with earlier stage disease, rather than they have a different pattern of disease. In terms of family history, a history of ovarian cancer in the family is relevant, because they may well have a BRCA mutation. Obviously, a family history of breast cancer is important. One thing that you may not be aware of is there has been a change in practice in secondary care. So if a patient is diagnosed with an ovarian cancer, we will often do a genetic analysis regardless of their family history. So patients diagnosed with an ovarian cancer will have BRCA mutation testing performed. And it's quite interesting how many patients are picked up with a BRCA mutation who don't have any family history at all, but have a de novo mutation just affecting them. The reason why we are testing in secondary care is there's a new class of drugs called PARP inhibitors, PARP inhibitors that's available, which for patients with a mutation confers a longer interval-free and overall survival when we start treatment, in addition to chemotherapy. In terms of Lynch or HMPCC mutations, that's less common as a cause of an inherited risk of ovarian cancer, and certainly a Peutz-Jeghers syndrome is again very uncommon as an increased risk of ovarian cancer in terms of clinical practice. Next slide, please. So just
Rahul, I'm just going to
we're
quickly,
running out of time.
Yeah, we are.
Yeah. So next slide again. So I think this is the one that's most important in terms of the retrospective and case control studies looking at symptoms, and it's around persistence of symptoms. I've been told if you speak to a perimenopausal woman, every single one will complain of these symptoms, and I'm fully aware of that. But I think the issue is it's about the fact that they're persistent over a 1 or 2 month time frame, and the fact that patients may consult frequently that should trigger the investigation. Thank you.
Thank you so much. We haven't got any questions, but if anyone has any following this webinar, then please pop your question in the Q&A box, and our panelists will answer those, and we'll also circulate those after the webinar. So thank you, Esther. Thank you, Rahul. So right. David, over to you.
So next slide, please. So everyone's worried about pancreatic cancer, I think both doctors and patients, because everyone knows prognosis is very poor. This abysmal 5-year survival of about 5% and a 10-year survival of 1%. And most people know if they get pancreatic cancer, there's nothing we can do. And there's really, the other unfortunate thing is there's a lot of patients affected really from the age of 45 onwards. And therefore, I think there's clearly massive room for improvement. But what I'm going to do is talk about the current situation and with reference to looking at it from secondary care. To see what we can do if we can improve things in the future. The main issue is that once the patient has symptoms, it's essentially inferring that the cancer is spread outside the pancreas and therefore is inoperable. But the other thing to consider is that the treatments for pancreatic cancer, both chemotherapy and surgery, are both fairly devastating for patients. And the other slight issue is it's actually quite difficult to diagnose pancreatic cancer. For every case we diagnose, we discuss 5 potential cases which turn out not to have pancreatic cancer. And that's a lot of tests, a lot of anxiety for patients and doctors. Next slide, please. This is just the age distribution showing that the median age is 75. It is a disease that's increasing in all age groups from the age of 45 onwards. So unfortunately, we are seeing some devastating diagnoses in the 45 to 60 age group, and obviously increases with age. Next slide, please. I'm going to make reference to an audit where we essentially looked at all the patients who were discussed in our upper GI multidisciplinary team cancer meeting in 2019. Everything makes reference to that 1 year period. And then I'm going to talk about what we might be able to do to improve things. I know direct access CT is something that Esther and I have talked about in the past, and whether that has merit, whether we can improve the pathway, what might be available in terms of screening for pancreatic cancer, and any new technologies on the horizon, which I think is where our improvements will lie. Next slide, please. So this is just to show you what we discussed in our MDT meeting. 220 patients discussed, and HPV cancers make up about 20%. But the other thing to notice is that discussion of benign cases is also substantial work burden. So these are patients who we think are suspected cancer, but after their workup found not to have cancer. And the only other thing to point out here, which is a favourite thing of mine, is that we also end up discussing a lot of patients who turn out to have cancer but not upper GI, so colon, renal, lymphoma, haematological cancers. And the main reference for me is that increases the work of our pathway, because whenever you have to liaise with other pathways, it always delays the time to diagnosis, time to treatment, but also increases the workload of your pathway because it's no longer linear. Next slide, please. So just this is just a, I'll probably cut over this slide. It's just to say these are the cancers that we find other than upper GI. Next slide. So pancreatic cancer, if you look at just the patients who turned out to have cancer, we're looking at about 1 in 5 patients discussed having pancreatic cancer. Next slide, please. Now, if you talk about pancreatic cancer, it's difficult not to also think about a cholangiocarcinoma, particularly as I'll show you in a second. Quite a few patients who are diagnosed with pancreatic cancer turn out to have cholangiocarcinomas. This is a cancer of the biliary tree, usually affecting the bile ducts, the gallbladder sometimes, and the bile ducts within the liver. And of course, the prognosis from cholangiocarcinoma is even worse if that's possible. And a few cases of gallbladder cancer, and we won't talk about it here, but the big concern is, do gallbladder polyps cause gallbladder cancer? And the answer is not really. We also spend a lot of time talking about benign cases, and this new concept is introductional pancreatic mucinous neoplasms. And the best way to think of these is like polyps in the colon, which harbour malignant potential. Not all polyps will grow in the colon. It's exactly the same in the pancreas, that if you look at IPMNs, as we obviously abbreviate it, about 1% of these a year will become malignant. But obviously, if you're diagnosing these, particularly in younger patients, we need to have a good strategy for following these up, because this may be the precursor for pancreatic cancer. The holy grail is identify the cancer early in a group that you know are at risk. Next slide, please. That, incidentally, is an IPMN in the pancreas. That's a side duct IPMN. You can see the dark splodge in the pancreas, and those are the sort of things we want to follow up. If they develop worrisome features, very similar to ovarian, if they develop solid components, cystic nature, or they go over 20 millimeters, then we're going to suggest sticking a needle in it, sampling it, and seeing if there's malignant cells. Next slide, please. So we got a list of all the patients that we thought had pancreaticobiliary cancer. And actually, when we looked at each individual case, we found that only 27 of them actually had cancers within the body of the pancreas, which might surprise you. And in fact, if you look at that further, only 20% of those were what we'd consider to be pancreatic adenocarcinoma, the cancer we really should be discussing here. And this highlights that oncologists don't want to give chemotherapy to patients unless they know histology, because there is separate, completely different outcome for neuroendocrine tumours of the pancreas, tend to affect younger patients. Metastasis of the pancreas should be treated as per their tissue of origin. And of course, lymphoma has a completely different prognosis and treatment strategy. So you won't find any oncologist anywhere who will give patients chemotherapy for pancreatic cancers without knowing the histology. Next slide, please. Now, if you actually look at the 20 patients who are diagnosed with pancreatic cancer adenocarcinoma, you can see age range 47 to 91, median age is 74, which is what we'd expect, male predominance. Unfortunately, 25% under 60. Interestingly, none in between 60 and 70, so there's almost like 2 peaks of age, younger patients and older patients. And again, exactly paralleling what we'd expect from population studies, distribution above and below 75. But the really interesting fact, which I found quite sobering, is that 90% of these patients were diagnosed through inpatient admissions. So these are patients who are admitted, subsequent imaging shows malignancy. Only 1 patient came through the upper GI 2-week pathway, and 1 other patient came from a patient having a CT of the chest. And in fact, this was the patient that was resectable and had a Whipple's procedure, because it was essentially picked up incidentally in a patient having a scan for another reason. Next slide, please. If you look at treatment for these 20 patients, pretty much all of them had an ERCP, so you can infer they were jaundiced, and that's how they presented. 1 patient had a curative Whipple's, which was the one picked up incidentally. Only 2 patients had chemotherapy, including the Whipple's patient, so that was an adjuvant chemotherapy. So 1 patient had palliative chemotherapy. 1 patient declined chemotherapy, but was deemed fit enough to have it and was advised to have it, 57-year-old, but declined because of mental health. And 18 had best supportive care, so essentially palliative care and no treatment. Next slide, please. Of those 20, 18 are deceased. The 2 alive patients, so the 1 had the Whipple's and the 1 declined to have chemotherapy. The median survival is 80 days after MDT diagnosis. So that really shows you how late stage these patients are when they're diagnosed. And in fact, they're all nearly all deceased by 6 months. Next slide, please. So where can we go? What can we improve? Next slide. Now, I personally am not a fan of direct access CT because I think all you're doing is changing when the CT is done. I think that I know NG12 recommends it, but there's a massive problem with radiology provision. CT is actually not a big issue, but provision of MRI is a massive problem. But the main problem is shortage of specialist radiologists. So we don't have enough radiologists to report pancreatic CT. It's quite a complex thing to report. It's frequently missed by non-specialists. So there's no point in having thousands of CT scans if it's not being reported by someone with experience. The other issue is about imaging interpretation. Every year I've been a consultant gastroenterologist. I spend a large part of my week interpreting CT scans, and it becomes a minefield because the CT is not a truth machine. It misses lesions, it picks up lots of incidental lesions, and it's very easy for me as a gastroenterologist to ask my consultant radiology colleague, the one I trust, about GI radiology, to interpret a scan and reassure me or tell me further investigations are needed. And if you don't have that infrastructure, you'll spend a lot of your time being anxious about patient scan results. And this is not just the MDT, this is also outside the MDT. Obviously, the detection rate has gone down as we've done more scans. And as I said, the incidental finding rate is 10 to 30%. I spoke to a colleague of mine, a radiology consultant at the Royal Free, and he said they introduced direct access CT scanning. It was popular for about 3 months. And he said after people had received a phone call at 5 o'clock on a Friday saying, this is your CT scan result for your patient with pulmonary emboli or things that he felt needed urgent attention, so the rates of requests went right down. And in fact, now patients are mainly being referred back on the pathways. But I did speak to others, and I couldn't find many radiologists in particular who were keen to have this as a strategy. Next slide, please. So in terms of the pathway focus, do patients attend their GP late? Yes, absolutely. That is the problem. We need to be able to go back at least 3 to 6 months, possibly 12 months before they're attending the GP surgery. Is there evidence of delays in referrals? Perhaps. I'm saying perhaps because not every patient is referred at the first visit. Are there delays in hospital investigations? I don't think there are. The way the pathways work now is really quite effective. We're getting patients seen within 7 days, or pre-COVID we were. Now we're struggling. But the hospital often does incorrect tests. I'm absolutely aware of that. Some patients come, they have an OGD, don't have a CT. And as I've said to you before, we've got clear evidence of patients having scans that aren't interpreted correctly. And we have in fact, next slide, please. This is a case of a 60-year-old man who had weight loss, a high-risk symptom, had an OGD, had a CT. There's actually a clear pancreatic cancer there, looked at by a non-specialist radiologist. 9 months later, we get a phone call from another hospital saying, can we have the previous scans just out of interest? And there's the cancer, and I can see it. But of course, I don't look at scans of all the patients. And it was just, the problem is a non-specialist radiologist reporting the scan. This is obviously a single slice I've taken that highlights the issue. When you're reporting scans, you've got 300 slices. Next slide, please. I'm just not too long to go, but in terms of tests, I was interested to read the article Open Access in the BMJ last week, looking at weight loss in patients, a huge number of patients, and only 1.4% had cancer, but the risk of cancer, or the rate of cancer, increased if patients had certain determinants, including being over 50 and having ever smoked as a male. Jaundice, obviously, patients with abdominal pain, but age was a key factor. Obviously, we should be aware of patients who have IPMNs, because if they have intercurrent symptoms, they clearly need to be rescanned. Alcohol and previous pancreatitis are risk factors. Epigastric pain, obviously very non-specific. Fullness, discomfort, really any symptom could be attributable to pancreatic cancer. And you're all aware of the new onset diabetes may be a risk factor, but I would point out, this is really important. So although it increases your risk by 2 to 6-fold, if you actually look at the study of pancreatic cancer patients, 0.27% of newly diagnosed diabetics had pancreatic cancer. So it's a really small proportion. You'll have to scan 300 patients to find one cancer. So don't get too focused on that. So what I'd say to you about this, one clinical advice I can give from my side of things is, if you see patients who you've not seen before with new onset symptoms, refer them if they're 50 or older. If you see patients who are constantly coming back with the same symptoms again and again, there are these patients who we all recognize, both sides of the equation, who are coming back for repeated cycles of investigation, gastroscopy, CT, etc. These patients very, very rarely have cancer. In fact, we're doing a study on it at the moment because we don't think any have cancer, but we'll look at it. Now, in terms of tests, I mean, again, borne out by the Hamilton paper, if you've got abnormal blood results, you're much more likely to have cancer. I think fourfold for pretty much any abnormal blood result. So these patients need liver function tests. CA19-9, I would not advise doing. I only ever check it when there's a lesion in the pancreas or the liver that we're trying to characterize. There's no other role for it. And it just causes endless problems because a percentage of healthy people have a raised CA19-9. And you're really looking at about 12 months of anxiety for patients and doctors if you test the CA19-9 outside of those clinical parameters. I don't know where this fashion has come from for checking amylase. It's probably from Pan-London guidelines, but I just don't think amylase has any bearing on pancreatic cancer whatsoever. Ultrasound's not a useless test, but it has very low sensitivity. So that unfortunately means it's ineffective for ruling out pancreatic cancer. CT is the best test, but it gives patients a year of background radiation dose. So essentially a good way of explaining to patients is you're a year older after having a CT of your abdomen. MRI is the best test, but we do not have enough access. Next slide, please. So finally, I'm just going to talk about new technology. I really don't think we can change the game in pancreatic cancer until we have new technologies. Two things to remember: genomics, so looking at people's genes, identifying who's at high risk, and secondly, systemic protein response. So this is assays that look at multiple cytokines, things in your bloodstream that would tell you that there's something going on in the pancreas. Until we have these technologies, I don't think we're going to improve things from where we are now. Next slide. This is simply a summary of what I've already said. Thank you very much.
Thank you, David. Esther, I think you're back, but I would just ask all attendees that if you've got any questions, we have one regarding ovarian that we can answer, and we can send round an FAQ after the webinar, so that's fine. If anyone has any further questions around pancreatic that you want to ask David and or Esther, then please send that to us. But I'd just like to say thank you to our panelists. They were wonderful presentations, and thank you for attending, and thank you to everyone who dialed in. I'm just going to go on to the next slide. That will have a list of our next webinars. So we've got a whole series going up right up until next March. And also please complete the evaluation form, the online evaluation form. So thank you so much. Take care, everyone. Have a nice rest of the week. Bye.